afternoon. MercyCare is pleased to be a gold sponsor of the 2020 Health Current Summit and Trade Show. MercyCare is among the largest access health plans in Arizona, providing access to physical and behavioral health services to approximately 400,000 members around the state. We serve families, children, seniors, and people with developmental or cognitive disabilities. Next year, we'll expand our services to include integrated physical and behavioral health services for Arizona's children who are involved in the child welfare system. Our continued support of Health Current and the annual Summit and Trade Show underscores our commitment to enhance care, improve quality, and lower costs through the statewide health information exchange. Each of these areas are catalysts for success in value-based care. Today's panel session on population health in a value-based world will provide insight on how 3 organizations are using data from Health Current to guide decisions, provide information to inform actions, create interventions, and monitor outcomes. MercyCare supports and promotes the use of the HIE in our value-based arrangement as well, and we look forward to today's panel discussion. I'm turning it over to Christy Dye.
Thank you, Jen, and MercyCare, one of our sponsors. Yes, slide, please. Welcome back, everyone. I'm really excited about this next panel, Population Health in a Value-Based World. I wanted to remind folks as we go through, you're welcome to use the chat feature to enter questions. We'll reserve some time at the end for answering questions. As Jen said, this panel will feature 3 Arizona organizations who are really leading the way in the use of HIE and other data for risk stratification, designing clinical interventions, and managing the health of high-risk patients. Our panel members today include April Rhodes, President and CEO for Spectrum Healthcare Group in Northern Arizona, and Touchstone Health Services here in Maricopa County. April also sits on the Health Current Board of Directors, representing behavioral health and integrated care. Dr. Michael Franzak is Director of Population Health Services for Copa Health in Phoenix and is well known in Arizona and actually nationally for his work in mental health advocacy. Dr. Franczak is joined by Micheala Statt. Micheala is a licensed social worker and Director of Health Information Management for Copa Health. And finally, Wendy Burkholder, Chief Clinical Services Officer for the District Medical Group in Phoenix, representing children's rehabilitative services, specialty care, internal medicine, and family practice. Next slide, please. So we just wanted to kick it off with a quick look at Arizona's progress toward value-based contracting in our state's Medicaid program. And this is the Learning Action Network Alternative Payment Model Framework. And those of us who've been providers or health plans in Arizona have grown to love and adore this model. It has been adopted by the Arizona Healthcare Cost Containment System, which is the state's Medicaid program access, who adopted the framework in order to guide movement from volume-based payment in healthcare to value-based payment in the public healthcare system. Next slide, please. Access has actually embedded the alternative payment model in many of its policy and contract requirements for health plans. Most notably, Contractor Operations Manual Policy 307, Alternative Payment Model Strategies and Performance-Based Payments, which actually establishes targets by year for which Access expects health plans to be contracting a percentage of their contract revenues into alternative payment model arrangements, so away from fee-for-service and into this whole risk and value-based world. Next slide, please. And secondarily, in Policy ACOM 306, which deals with quality performance measures and incentives, this particular policy establishes targets for set performance measures every year across the continuum of services delivered by the health plans, with incentives for successful performance and sanctions for health plans if they underperform. Next slide, please. So in the value-based world, having access to real-time data that's comprehensive is absolutely vital for provider agencies trying to succeed. The Health Current and the HIE is a great source of information for many of these types of data. Anything from alerts like COVID lab test results or ED alerts that really support real-time clinical management of a patient population, as well as allow providers to monitor their status in meeting performance measures at any given point in time. We also provide a lot of data provisioning for health plans, for individual providers, for patient-centered medical homes, clinically integrated networks, and that can be anything from utilization reports, performance measure reports, and looking at panels of individuals who have certain types of comorbidities. And then, of course, in our future, moving into the arena of eCQMs, electronic clinical quality measures. Next slide, please. And this really is just a quick review of various data sources that are commonly used by providers in population health programs, and some of the strengths and weaknesses. So the HIE is a great one because it's comprehensive. It'll cover alerts and clinical information across all providers that treat the person that are participating in the HIE. That's as opposed to claims, which are lagged, so it's 6 months behind, and are also very contingent on how well a provider does in coding and complete documentation of all the services that they render. So with that, I'm going to turn it over to April from Spectrum Healthcare Group. Next slide, please.
Hi, thanks, Christy, and thanks for the introduction, for facilitating, and thanks to HealthCurrent for having me here today. I very much appreciate having the opportunity to talk about population health and value-based reimbursement, which are obviously very important in our work. As Christy indicated in the beginning, I'm April Rhodes. I'm the Chief Executive Officer for Spectrum Healthcare Group and for Touchstone Health Services. For the purposes of our presentation today, I'm going to focus mostly on the work we're doing at Spectrum Healthcare Group as it relates to value-based reimbursement and integrated care. And so I will give you a brief overview of Spectrum. Next slide, please. So Spectrum Healthcare Group was founded in 1965 in the Verde Valley, actually. For those of you who may not be familiar, that is up in Cottonwood, Arizona in eastern Yavapai County. We rebranded in 2013 to what we know now as Spectrum Healthcare Group and have provided fully structurally integrated care since about 2009. And so for anyone who has set out on the path to do integrated care or is trying to do so now or has any experience with that, you know that it's incredibly expensive. It can be very challenging in carrying that kind of care out. And there's been a lot of different challenges for Spectrum as we've tried on pretty much every type of integration before arriving at our current model, which is fully structurally integrated care, as I mentioned. And part of how we were able actually to make a negative margin positive is through various activities, which we could spend a whole session on. But some include, a deep dive into performance improvement, into time and motion studies of our primary care practice, different things like that. But a huge component of it was value-based reimbursement, which really was a difference maker for us. Next slide, please. But as many of you know, value-based purchasing and reimbursement can look a little bit like this at times. And certainly for us, when we set down the path of trying to establish some value-based purchasing contracts in 2015, 2016, this is a little bit how it felt. And so I was hoping today to share with all of you some of the areas that we've identified at Spectrum as critical components for our success for making this value-based reimbursement work. Next slide, please. So these are not necessarily listed in any particular priority order, although I would say that number one certainly would be a dedicated population health resource. And so I want to talk a little bit about what I mean by that. And one is that as we set out to do integrated care and to receive reimbursement through value-based arrangements, we, at that time, around, like I said, 2015, 2016, the population health care manager at the health plan level was very popular. And in that type of a scenario, we would have a person at the health plan kind of guiding or directing what things we should be paying attention to, or what, we would be kind of at the mercy of their priorities. And so we made a concerted effort at Spectrum to bring that resource in-house. We wanted to be able to drive that process ourselves focus that population health resource on the areas that we thought made the most sense. And then we'd be able to have a little bit more freedom around what we're looking at instead of just focusing on some of the measures that we're used to seeing around readmissions and things like that. And I'll talk a little bit about what I mean by that in just a second. But another critical component, as I think is probably common sense, is the electronic medical record. And for Spectrum, this has been an ongoing challenge as we've navigated the path of delivering integrated care. One of the critical components of that is really having a single record. And for us, we've tried a lot of different solutions to meet that need. And even as recently as this past year, have found ourselves working with 4 electronic medical records through acquisition into Western Yavapai County and expanding our base. We've ended up with 4 medical records, 3 primary care and 1 behavioral health. And we've been able to consolidate that down into 2 now, but really striving to have a single record because that makes a big difference in how you pull out data, as you can imagine. Also, a critical component is the health information exchange. We're here talking at the Health Current Summit, so it's obviously important to all of us, but for Spectrum, for sure, the HIE plays a critical role in giving us the information that we need to have, which is the next item, to have actionable data, to be able to, in real time, determine a need, for example, as it relates to maybe post-hospital discharge or readmission, and then to develop a plan for what to do with that data. And so as the HIE has evolved and as our participation with that has evolved, we've been able to see some real progress in our success with meeting measures as well. Also related with the actionable data and plan piece that I think is important to share for the purposes of anyone trying to put these contracts in place now is that in order to make a real difference on these measures, you need to have more lead measures versus lag measures. And that was another critical component to bringing it in-house for us, is that we wanted to be able to see ahead of time what was going on with our own data so that we could make changes, more frequent changes versus more lag type changes. And so the other thing that we've been able to do is work with our health plan partners to develop timely access to their information and their data, as well as develop contracts where we're getting more timely, frequent payments so that we're able to see that immediate reinforcement of the work that's happening. And then lastly, and again, in no order of priority, a huge difference maker for Spectrum too was implementing an incentive sharing plan. And so we felt that it made sense that if we wanted to engage our employees around how to move the needle on some of these measures, then it would make sense to share some of the value-based reimbursement that we're receiving as a result of those efforts. And so over the last couple of years, we've implemented that incentive sharing plan, and we have seen a real difference in how we do performance-wise on those measures. And I'll talk a little bit more about that later on in the presentation. So next slide, please. I just wanted to give an example here. I'm not going to spend a lot of time here, but as I was talking about bringing population health internal and it freeing us up to focus on other areas other than just the standard set of measures that you'll typically see, we also use our population health team and quality departments to focus in on measuring outcomes for other areas of focus, such as our mobile crisis response, for example. One of the things we want to be able to do is measure the stabilization rates and our response times, post-event follow-ups, things of that nature. Also with our work adjustment training program, which is essentially our program where we are helping our members living with serious mental illness to learn soft employment skills in-house and then be able to help them achieve employment in the job market. And so we obviously want to be able to measure things like their graduation rates and their employment placement. And then we've also been able to look at year over year what the impact of that kind of care is on the annual cost of care per member per month, because for this population, we are in a subcap arrangement that is risk-based. So all of that is very important. Another example is our pain management program. And this is where I think having very timely, actionable data is critical, because as we launched Spectrum's pain management program, one of the things we wanted to demonstrate was that when you add things like massage or acupuncture, then you will have better outcomes and overall improvement in the quality of life. And without our own internal monitoring of that data, it makes it difficult to produce that information real time. And we share that information with the payers, which then can translate to value-based reimbursement opportunities for us. Next slide. So I'll talk a little bit about some of the value-based reimbursement agreements that we have that are related to the health plan. And so this is just a list of some of the agreements that we have. It's not exhaustive, but they're kind of our larger contracts. And I want to give a couple examples of some of the things we're looking at. And so I will share on the next slide, please, an example of what some of the measures look like for the different plans. This is not novel or groundbreaking by any means for those of you working with these, but this is, basically what we're looking at, and some of the measures where we're meeting the measure, and then areas where we're not meeting the measure. And so this is information that we're looking at on a monthly basis, and then making tweaks to how we're responding and sharing this information. I think it's a critical component to point out that we share this information in real time with the employees that are participating as well, so that they know how we're doing and they can make kind of real-time decisions about how to impact that data on the front lines. Next slide. This is just an example of Blue Cross Blue Shield. There's not a lot of difference. I mean, there's some nuances between the different plans, but they're all kind of looking at the same things. And so this is just an example of some of the things that we're looking at and how we trend things over time as well to see, how are we doing in different areas and making improvements or not. Next slide. Another one, Humana, this is a very interesting example as well, because with Humana, we're looking at our STARS rating. And anyone who's worked with STARS ratings knows that it can be difficult, particularly if you have a small N, to move the needle on those STARS ratings in the slightest bit. And so we want to be looking very closely at how are we doing compared to last year? Where are some areas where we've gone down so we can target our focus, or where are some areas where we've improved so we can celebrate that with staff. Next slide. And again, lastly, the Care First example. This is one of our favorites because we do get really timely information back, and we get to work closely with that team and monitoring these results and sharing information and celebrating successes together. And we've seen some really good results from that arrangement. And there's a whole lot of ways that we're able to use this information in real time. Next slide. So again, back to the incentive sharing. I bring this up again just because I think it's a very important component, and it's made a big difference for us. But there's some things that are important to share related to that, because part of why I think it works really well, and it's the same reason why we have different levels of success with those health plans that we have ongoing timely communication and a more frequent payment with, is that we're being very transparent with staff around how we're doing on the measures and when we receive dollars, to the point where it's a weekly reporting from finance. Anytime that we get a payment in under a value-based reimbursement arrangement, we're reporting that out in an all-staff message saying, hey, we received this amount of dollars from this payer, so that staff can know when that money is coming in and what cadence. And then we're reporting how we're doing on all of those measures, as I said, in real time to employees, so they can see pretty frequently how the organization's doing. And they know that if we're doing well, they will do well. Next slide. So, the plans for Spectrum for the future, really, as I said, our big priority this year is to focus on that single EMR. We believe that is the very next thing we need to do to get to next level with data reporting and being able to really move the needle on our value-based reimbursement models. And so we're working through that, and there's lots of other things that, that can't be covered in the small amount of time, and I want to be mindful of time. I know we need to move on to the next presentation, but I will be here at the end to answer any questions that anyone has specific to Spectrum. Again, I appreciate the opportunity to share with you today and to present virtually. It's a new experience. And I'll hand it back to Christy.
Next slide, please. And now I'd like to bring on Dr. Michael Franzak and Micheala Statt from Copa Health.
And I think Dr. Franczak is speaking, but it looks like he's muted.
Okay, thank you for pointing that out.
You're welcome. It's the virtual world we're in.
Good afternoon. Micheala and I are going to alternate slides, and we're going to start with Micheala telling a little bit about Copa Health.
Okay, thank you, Dr. Franzak. Good afternoon, everybody, and thank you for the opportunity to present to you today. Copa Health is an organization that was formed by two longstanding organizations in the community, Partners in Recovery and Mark Community Resources. And we provide a wide variety of services across Maricopa County. Some of those services include 7 outpatient health home or outpatient campuses, as we refer to them, serving both seriously mentally ill and general mental health substance use disordered folks. We have 5 ACT teams across the Maricopa County system. And we also have 5 of our health homes are completely integrated models with primary care services on site. On the formerly known Mark Community Resources side, we provide employment-related services, housing and residential services, day programs, health and wellness services, counseling services, a kind of a wide variety of peer and family support, and really under the Copa Health umbrella, kind of provide an overall whole person approach to care. So that's what we do as Copa Health as an organization. Today, our presentation is going to focus on mostly what we've done on the outpatient or the integrated health home sides with our locations that are providing direct care to SMI and GymSU folks. So I'll hand it over to Dr. Franczak.
Okay, next slide, please. Okay, so one of the things that we found, and I'm sure many of you have found the same thing, is there's lots of data. In some ways, we're swimming in data. We get data from the HIE, we get data from our payers, we get data from our own records. So it's very important that we figure out exactly what data we can use to take action. So we're in our population health field. We focus on the entire population of individuals we serve, particularly those with high utilization of emergency rooms and hospitals, those who are high cost, high need, people who have gaps in care, factors that are related to social determinants. And our goal is to improve these behavioral health and physical health outcomes using a care management platform. One thing I've noticed today is that in addition to the HIE providing us with valuable information that we can use to meet our goals and objectives and contract requirements and our incentive payments, is that the HIE, and it was clear in many of the meetings, that we're all sharing a similar population and all having similar experiences with trying to pin down interventions for those populations. When I heard the EMT discussion, it could have been us doing the conversation because we're having the same thing. So in addition to giving us data, they're creating a partnership or relationship that we could use to solve problems. So it's bigger than just sharing information. Next slide, please.
Yeah, so Dr. Franczak briefly touched on data sources, and I know April alluded to this in her presentation as well. In order to have a successful population health program, you need to have a process for aggregating and evaluating all of your data sources. So just some of the data sources we use right now, of course, the Health Information Exchange. We have a single EMR for primary care and behavioral health, which is really helpful. We have some information manually being collected by discharge transition planners and care managers. We get claims data from MCOs, and we have a Tableau reporting system that some of our payers use as well. So when it comes to data, first we have to figure out how we can intervene or what types of data is real-time actionable information for us. So related to Health Current, we set up a process for which we get real-time ADT alerts for a very specific group of our population. And that includes members on ACT teams, members for which we've determined meet high-risk registry criteria, and members on court-ordered treatment. The reason for that is our resources across the clinical team structure are allocated in a way where if we get an ADT alert for a member who's in the ED in particular, we have the chance to intervene and meet that member at the hospital prior to perhaps them being admitted unnecessarily. So that's one of the things we utilize Health Current ADT alerts for. We also receive batch alerts, which really is helpful from a data aggregation perspective. We have a team that transfers all of this information into what we're calling an enterprise data warehouse. And that enterprise data warehouse then aggregates information from a variety of sources to come up with some risk stratification in your population.
I think you've frozen, Micheala, for some reason. Yeah, I can. Can we just go to the next slide? Micheala, you might have to. Oh, you've thawed out now. Okay, so decoding the factors that we see in our data, we have something Micheala's going to talk about called the functional risk analysis. The functional risk analysis is that we take our data and then we use a concept known as digital exhaust. Digital exhaust is what Amazon and any other online shopping uses to determine patterns of behavior. Individuals who are using emergency rooms at high frequency or using hospitals at a frequency that seems unusual and sometimes unnecessary are making choices to do this. By tracking the choices, by getting the data from the HIE and then some of our other analysis, from the choices, we're able to identify the person's preferences. From the preferences, we're able to identify by digging a little deeper into the why. And by understanding the why, we are allowed to develop interventions that are more targeted to the particular function of the behavior. Now, one of the things that we've been finding, and here's a list here, we've been finding some of the individuals are going to ERs or hospitals unnecessarily because undiagnosed or untreated chronic medical conditions. We've done some analysis to see that many of the people using ERs are using the ER as their health home. They don't have any connection with a PCP. The last time they've seen a PCP is 2 or 3 years ago, if they've seen them at all. So, and ERs and the EMT have a 24-hour service. Most PCP offices are not open on that schedule or on weekends. Then we see people who are shopping, doctor shopping for opioids, and we can track that pretty good quickly. We should see location and proximity, that people are using, instead of using our clinic, which is 10 miles away, they're using another clinic or an ER that's 5 miles away. I've already mentioned the ER as the health home for many people. We've already seen in our social determinant area, housing, that quite a few individuals are homeless or living in unacceptable conditions, and they're using hospitals to obtain housing, to get warm, to get cool, to get a shower, get a change of clothes, get a meal. And often are coming into the hospital saying, I'm thinking of committing suicide. And of course, hospitals can't turn people away with that presentation. But in fact, when we track those individuals, they're out the door in 2 or 3 days because the hospital can't really see any suicidal plan. Food insecurities. People are going to emergency rooms to get lunch. And while they're there, some are going because they're socially isolated. And emergency rooms are very welcoming. Family relationships are stressors. I want to get away from my mother. I want to get away from my husband or my wife. We also see finances. So by digging a little deeper into the reason for the behavior, we're able to see preferences, and then we can address them more specifically. Next slide, please.
This is Micheala. I hope I'm back now. Thank you, Dr. Franczak. So what I was speaking to earlier is that we've used information from the Health Information Exchange to risk stratify our population into folks for which we can really intervene and make a difference in overall cost of care and improved health outcomes. So we've used this data primarily from Health Current and some other sources to create a high-risk registry. And we have a pretty detailed process for which we have care managers and staff supported in completing what we call a functional risk analysis and really getting into the why on why folks are utilizing services. Is it because of their medications or their diagnosis? Is it health literacy? Is it SDOH needs, as Dr. Franczak alluded to? And we've had some really, really good success in kind of the reduction of overall utilization, not only from a psychiatric inpatient hospitalization perspective, but also from an emergency department perspective. And the reason that we know we're having success is that we can evaluate and aggregate data on an ongoing basis because of what we get from the Health Information Exchange. I think Christy alluded earlier, and April did, that using claims to monitor value-based care becomes challenging, especially because there's such a lag. But the real-time information we get, in particular related to ED utilization and inpatient medical facilities, has really helped us monitor progress over time and the reduction of overall utilization for folks on our high-risk registry. So, next slide.
Yeah, this is a little example of a group. As Micheala mentioned, we develop a high-risk registry, and it's based on utilization of hospitals and emergency rooms. And then we take that registry, and as Micheala said, we dig deeper into the whys. This is just a small example of a cohort over April through March that we tracked on emergency room use. And one of the things you have to do is, in addition to getting data and take baseline data, we have graphics on everyone's yearly utilization. And then what we do is monthly feed back the data, showing if our intervention is being effective, and if not, do we have to adjust the intervention? As Christy and Micheala have said, relying on claims data, which is 6 months old, I liken to driving a car, only looking through your back view mirror. And then it's not only the immediate past, it's 6 months old. So I don't think you can get very far in doing, immediate corrections by using that as the only data source. So we've had to count on the HIE. We've had to count on data we get from our funder and any source that we can grab to have an immediacy to it. Because when you intervene, you can't wait for 6 months to see if it had an effect. You'll be just wasting your time if it's ineffective. So this is just a quick example of the process we use and the reduction we've had in emergency room use. Next slide, please.
Yeah. So why is this important for us as an organization? April spoke to this earlier too. Healthcare providers are really kind of challenged with being successful in this value-based space in order to have kind of longevity and to make sure that the programs are sustainable over time. And when you are in the process of negotiating value-based contracts with payers or various different entities, you have to be able to speak to your data sophistication in order to manage and monitor high-risk, high-cost members. So the process that we've developed in order to risk stratify, really kind of hone in on who our high-cost, high-needs members are, and strategies we've developed to reduce utilization have really well positioned us to be in a place where we are in value-based contracts with a lot of different entities. We've been very successful in the targeted investment program. We recently, this year, were able to use the Health Information Exchange specifically for diabetes screening measure, getting hemoglobin A1C values. That was a huge kind of missing piece for us, given not all of our folks get labs within our facility, and some of them get labs outside in hospitals or other specialty offices. So we have a process for which the data that we're using has really put us in a place where we can negotiate and position ourselves for value-based contracts, which is how companies are going to be successful in the healthcare space moving forward.
Yeah, one last point is many of the value-based contracts are either built on a calendar year or a fiscal year. It's really hard to manage mental illness care or physical health care when it's put on a timetable of that nature, because you have to make a rapid progress with people you identify that are 9 months into the contract. So value-based care really needs to have a longer timeline, in my opinion. Micheala, do you have any closing thoughts?
Excellent point, Mike.
No, I don't.
In that case, I want to swing us over to our final presenter on the panel for today. Thank you, Michaela. Wendy Burkholder from District Medical Group.
Hello, good afternoon. Can everyone hear me okay? So my name is Wendy Burkholder, and I'm proud to be introducing the District Medical Group to you today in our Children's Rehab Services Program, excuse me, which is a part of District Medical Group's clinics. So District Medical Group, for those of you that don't know, is the closed physician group for the Valley-Wise Health System. So we have a large book of business that we do as providers for Valley-Wise. In addition to that, we are honored to provide services at District Medical Group's CRS Children's Clinic. CRS is a program that's a multi-specialty interdisciplinary clinic. It's called an MSIC, and there's 4 of them in the state, with Phoenix being the largest, and Tucson, Flagstaff, and Yuma also having CRS clinics. Access has a great program where these children actually receive services and more extensive services and wraparound services in this MSIC model. As we do that, we provide care to the most vulnerable Medicaid population in the state of Arizona. Next slide, please. So as you all will see with District Medical Group, we serve approximately 16,000 patients at our clinic. We have a very comprehensive clinic, almost like all services under one house type of model. Not only is it a patient-centered medical model, but it's one that I tease that we have all of the ologies that you can think of. We have over 25 different specialty services in our clinic. We provide primary care services, behavioral health services, including psychology, counseling, psychiatry services, dental services, rehab services, including occupational, physical, speech therapy, audiology services. We have imaging on site. So we have a very, what is known as an integrated model, but even more so because we have 25 different types of specialists all under one electronic health medical record. The great thing about the services that we provide is that we have a lot of wraparound services as well. We have a patient advocate. We have 3 full-time social workers on site. We have also counseling on site that can help with any issues on the medical side that patients are having with regard to really dealing with the behavioral health aspects that come with having a medical diagnosis. Everything from, how do kids with cleft palate fight bullying in the schools and all of those comprehensive services. So it is a very, very comprehensive model to providing care, again, all under one electronic medical record. The interesting thing for us is because this program has such vulnerable kids and a vulnerable population, we don't just see kids in Maricopa County, we see kids throughout the state. As you can imagine, in Flagstaff and Yuma, where there's more rural care that is provided, the specialists quite often are not housed in Yuma for neurosurgery or for metabolic genetics. So we actually partner with the other MSICs well, and we use the services of Health Current to communicate along the way what's happening with our patients We do provide field clinics out on the reservations, and we also, prior to COVID and now with COVID, are doing a lot of telehealth as well to support the needs of our patients and families. Next slide, please. So with that, Health Current became a big part of what we did way before the expansion with the Target Investment Program, but we are a partner on Target Investment as well. We worked with Health Current very early on as part of really needing to identify our kids are fairly complex with medical issues, and it was important that we be able to communicate, one, what was going on with our patients, and also to get that information back, because even though we have so many specialty services in our building, it's very important that we know what's going on at all times with these kids, from their inpatient admissions to their surgeries, with the various provider groups. So we early on started on this journey with Health Current. We've been really in extensive partnership with them for over 5 years specific to this clinic, with really developing and fine-tuning the programs that we've had along the way. And they've been a phenomenal asset to us in understanding the complexities of our program. Just sharing that, you know, we partner with them on the opt-out forms, the opt-in forms, just some of the things that are required in order to share of information. So put a slide in here for you all on that. Next slide as well. And then with the Target Investment Program, we are a partner, as I shared with you, with Target Investment. We do have primary care and behavioral health milestones. I did not list them all here. April was able to also talk to you about the flow of those milestones and how we've been able to use Health Current to really share the data, one, amongst the participants in the various programs, but also at the state level with the different collaboratives we have, with sharing of information in the quality meetings that are part of the Target Investment Program. Next slide, please. So the other thing that the Health Current has allowed us to do, and also in partnership with the various health plans, is that we've been able to develop policies and protocols that help gain an understanding of the workflows. I think April was on earlier speaking to that and the impact of the workflows along the way with the complexity of the populations that we serve. But we get, just as everyone else does, the admission, discharge, and transfer, the Adt Alerts, specific for our population, which is a huge asset for us, because as you can imagine, when you have a more medically frail population and vulnerable population, how important it is to know when they've hit the emergency room and when they've hit the inpatient side. So not only do we get that, we also have you know, a knowledge immediately without having the process slowed down in any way by the sharing of data, by immediately getting that sharing of information from Health Current in a feed, instead of you know, the transition from the hospital to the managed care organization to ourselves. Then we also have the opportunity to look at how we can change, sorry, I have something popping on my screen, how we can use that information to coordinate the flow of services through our care coordination model, and also through really looking at how we can leverage our teams to enhance the quality of care that we provide to our patients. Next slide, please. Some of the Adt feeds that we get, and we've actually leveraged, and I don't know how many, it'd be interesting to see when we have the questions and answers at the end, how many have leveraged getting the COVID alerts. With our children, knowing when they test positive for COVID was a huge asset to the organization, because we do take care of some fairly medically compromised kids. And so knowing and being able to develop alerts into our EMR when we found out through Health Current that they had tested positive has really helped us to impact the care that we provide. One, making sure that the staff are all aware that the child has tested positive, but also so that we can proactively reach out to those families and provide education to them on, you know, well care, not spreading the transition of disease, and anything support services that they might need. We also use the information, as you can imagine, if they have had discharges either on the behavioral health side or the medical side of the hospital, to get them into care as soon as possible, and to really one, be more preventative from them having to have avoidable admissions in the inpatient stay by really maintaining well. We look at the behavioral health and the medical risk scores of the patients as well, to see with all of the patients being medically complex, it's even harder to take and look at. We have the sickest kids, and I say we always, my mantra is we have the sickest kids in the state, but then you take the sickest kids in the state with the social determinant of health issues, housing insecurities, food insecurities, and then you pile some of their cognitive and family dynamics on top of it, and it makes for a really challenging population. And then taking that and creating a subset of those that are the highest risk, when most of our patients would be your high risk patients. We have a higher risk registry of patients within the complexity of children that we provide, that we have actually tagged into the Health Current system so that we can manage those patients at a higher level. With those specific patients, they are actually seen every 90 days to really make sure that we're providing as much wraparound services and as much support as we can for them. We also have in our MSIC what are called planning clinics, since we have so many different providers that might be involved in the child's care initially, and then annually thereafter. The providers all get together. The patient comes in for care. We'll see all the providers that day, and these are called planning days for us. And then the providers get together after they've all treated the patient, and they have a post plan, and they develop their plan of care for the next year. So again, using Health Current data and getting all of the planning partners. Again, some of these kids might have 7 to 10 different type of doctors, and getting them at least in the room once a year to discuss the care plan of the patient and do that with the family members has been very successful for us. Next slide, please. We again look at the ADT alerts, as I shared with you before, to really identify how we can manage the flow of the patients. We print or download the discharge summaries into the system, and we scan the documents in the EMR. I know that some of the sites have those direct feeds into their EMRs, and there's different groups that have progressed further, or some groups that are further behind in their transition with Health Current than we are. But we are proud of the work that we've done so far, and anticipate we are going, as with all healthcare, and I know that I'm speaking to a large audience from all different areas, but healthcare, if not anything, it's ever changing, from the fact that we're in a summit today where we are not in a face-to-face meeting, and also, you know, the care that we provide every day. If you think about January and February pre-COVID, they are nothing like the care that we are providing now. So in this ever-changing world of dynamics, the partnership and the relationship with our health plan partners, with the hospitals, and with and with Health Current is huge in allowing us to kind of really ensure that we're, meeting the needs of our patients best. Next slide, please. And so some of the, and I know I have a minute left, we had a little bit of technology in the way, so I'm going to talk a little faster than I already was talking anyway. But as April had shared with you, we have some of the same metrics, and I think Christy shared a little bit at the beginning as well of the metrics that we have on avoidable ER visits, avoidable admissions, improving the dental and immunization rates, which are so very important now, especially with COVID, improving access to care, and improving, as I shared with you, our high-risk patient base and the care that we provide to the most fragile patients. Next slide. And this is just a little bit of data on our admits per 1,000 member lives. If you'll look at the trend of improving using Health Current in the volume, decrease in the volume of inpatient admissions per 1,000, as well as the ED visits per 1,000, so that we can achieve great results by the communication that we provide, not only that we receive from Health Current, but then we utilize to change the workflows within the clinic to ensure that we have a healthy, very well-educated patient and family population base. So with that said, next slide. So again, uploading patient panels, communication and updates are sent regularly, and ongoing trainings are provided. And what I would say is I think that we all agree that all of the folks on the panel wouldn't be where we were at without the successful partnership with Health Current and with the health plans to really look at the care we provide. And it's a shared responsibility we have for maintaining the healthy lives of our patients and families. And we are so honored to do that. So with that, I transition to Christy Dye, who's going to follow up with the questions and answers for us.
Thank you very much, Wendy. And actually, we have a number of very interesting questions in the chat box and only about 4 minutes to cover them. So I want to hit one that I think is sort of global. So you all talked about ways that your organization had used ADT alerts, particularly as it relates to emergency departments. I think each presentation touched on that. What are really the challenges in getting started of using those types of alerts to inform either a real-time intervention or some type of data management report, utilization management report? Whoever would like to respond.
I can respond, Christy. This is Micheala. I think one of the challenges or things you need to identify is who's going to get the alerts and at what process that's going to happen. Your notification and distribution process is extremely important. And then an ongoing process for managing as staff leave or positions change, who continues to get those alerts moving forward, I think is kind of something that really creating that infrastructure for how alerts come in, how they're managed, and what the follow through is there is really, really important. Getting alerts is one thing, but what do you do with them and who gets them and making sure that it comes through the right way?
Yes, Micheala is absolutely right. Getting data is important, but what you do with it is really what makes a difference.
April or Wendy, any thoughts about any challenges experienced and how you really get it streamlined? Your data, how do we get it streamlined? How do we make it actionable?
Yes, for Spectrum, I would say, a lot of our challenges can be tied back to the multiple electronic medical records, but it would be similar to what Micheala said. Even with that, we get the alerts, and then we have to figure out which EMR we want to push that through, or which one do we need to go to find something. And so it requires, a lot of manual hand mining at times.
I would agree with that as well. Again, data is not anything in a silo. It's really, and Michael said this best, it's the managing of that data that's so important to impact the patients. I find that we have a lot of success as well is in really partnering with our health plan partners. to really help them understand where we're at with our patients, what the concerns are specific to our patients. The health plan partners have been amazing with COVID and helping us to literally asking what our needs are, helping us to, you know, we help them to see the view of the patients through their eyes. And then they have been really responsive with us and getting the needs of the patients met. So I think it's all not only about managing the data well, but it's about the partnerships that you create with other players, including, you know, the specialists, your health plan partners, and Health Current to basically make it happen.
Thank you. Okay, we only have 1 minute left. So what are you not getting from the HIE today that you would like to get in the future that would make the magical world of value-based kind of work for you? I know some of you talked about A1C data, ED data, hospitalization data.
I think, Christy, for us as a, you know, largely behavioral health enterprise, the whole part 2 psychiatric, you know, the hospital information is really kind of where that missing gap is for us. And obviously there are legal ramifications and part 2 consent management processes and things that are in place that, you know, are barriers to certain facilities, you know, sending information to the HIE. But I think that's a well-known fact for providers such as us, is getting that psych detail would be very, very helpful, especially from the psych subacute facilities across the board, because the coordination of care with those facilities in particular is really an area where we think we can intervene and really reduce some utilization if we were notified real time.
Excellent, thank you. Anyone else? Last chance. Okay, well, I really want to thank you all. I mean, this was outstanding. I will have to send you the questions that we're not getting to. There's a lot of interest in this session. So really appreciate your time and willingness to share some of the inside secrets, some of your recipes for success with this audience and the value-based world that we're heading into. With that,
Thank you so much, Christy.
thank you all very much for participating.